Welcome to this edition of the AUA APP Newsworthy webinar series. Today's session is focused on the role of the advanced practice providers, or APPs, in the multidisciplinary management of bladder cancer. My name is Dr. Aviva Asnis-Alabozic. I'm a urologic oncology physician assistant and doctor of medical science, and I'm honored to be joined today by a panel of two highly experienced urologic oncology APPs. I'd like to introduce Michael White. Michael is a physician assistant with Urology Partners of North Texas, a member of the nationwide Large Urology Group Practice Association. Michael has over 19 years of clinical experience in urology and genitourinary cancer care. Welcome, Michael.
Thank you.
Next, I'd like you to meet Nazi Zamarodian. Nazi is a nurse practitioner and associate professor at the David Geffen School of Medicine at UCLA. Nazi is the director of the GU Clinical Trials Program at the Institute of Urologic Oncology at UCLA and comes to us with 26 years of experience in practice. Welcome, Nazi.
Thank you.
I'm really excited to be here and to start this evening's session with a discussion about the MDT. What I'd like to do is ask each one of you to think about the multidisciplinary team that exists within the context of your clinical practice, specifically focusing on bladder cancer. Michael, maybe I could start with you. Tell me a little bit about how that's structured, and importantly, what is the role of the APP in that team environment?
Yeah, sure. So working in a large urology group, a private practice in the DFW area, we have things siloed into the practice, specifically for disease state awareness and treatments. We work as a team with a lead physician, a lead APP, a nurse navigator. We have two nurses, treatment nurses, and then we have a team of about four medical assistants. We use that team to structure, diagnose, educate, treat, and follow that patient through their journey with their treatments. I think the biggest thing with this is this lends itself to making sure the patient is provided proper follow-up, proper initial treatment discussion, and then making sure that patient, if there are problems along that treatment journey, they're addressed up front and very quickly. And many times the APP is the one that's seeing these patients routinely after that initial visit that maybe the physician does that initial consultation. We're the ones that are seeing the patient maybe for surveillance cystos. Maybe we're doing the biopsies after a TURBT and the patient's had treatment, making sure that, if that patient needs to be taken back to the OR, we're guiding that therapy. But I rely very heavily on my teammates, whether it's the nurse navigator or even my MA who's been with me for almost 10 years, making sure that they're communicating with the patient while I'm in clinic, seeing other patients as well. So I think it takes a village in terms of treating and diagnosing and following these bladder cancer patients, because it can be a very, very complex treatment.
Thank you for that. Nazi, you're at an academic institution relative to more of a community group practice. What does the MDT look like in your setting with respect to the bladder cancer patient population, and what role specifically are you playing?
Well, in the academic center and teaching hospital, we obviously have more people that in our care team that they need to be educated and roll in to what their specific roles are. Unfortunately, we do not have the bladder cancer nurse navigator in our academic center. We do have for other diseases, so hopefully maybe in future we will, because it would be very helpful. So because of that, I think our nurse practitioners and PAs are basically playing that role as well. And I always say that the APPs in GU cancer, they're more like air traffic controllers and co-pilots. So we're wearing different hats as needed. And so, as Michael said, the initial diagnosis or diagnostic test may be done by the urologist, but these patients end up to be in our hands as an APP. And we basically taking a role of educating the patients, the care team, and also the caregivers. And once we decided what would be the course of action for the treatment for these patients, then we get the ball rolling, and then we get the nurses in the clinic to be on board. We have a very large clinic. So in our 15 exam rooms, we have 20, 25 nurses, which is RNs, LVNs, and MAs. So who you see this week may not see next week when you're giving the patient's treatment. So we make sure that the patient knows that whoever comes for that specific visit, they already been trained, they already been educated, and they know about the patients. We obviously have lots of treatments now in this space. So we have to make sure we kind of tailor-made and individualize those treatments for specific patients based on their medical history, their individual histories. We're living in a place that it takes an hour to drive 8 miles to get where you need to go. And in the greater spaces, that the transportation is the problem. We have to make sure the patients or whoever needs to give them a ride, they're available. When you do all of this planning, you have to know that you're not dealing with this, in the lab. This is in the real world, and the patients and their caregiver are actually have, other responsibilities. So you have to put that all in prospect of what you actually deciding for the patients to do.
Thank you for that. As the air traffic controller, I would say, of this multi-specialty team, do you have tentacles and connections with other types of providers and specialists like medical oncology or radiation oncology? And how do you manage that to ensure that everything stays connected?
Well, since we have an EMR and, the electronic medical record has helped a lot with the communications, and everybody documents, but I actually rely on the group of APPs that I know that in different areas of expertise. And I think that to get the patients to go to other specialty as needed, as a medical oncologist or radiation oncologist, is really important that for us to have that group of the APPs in different subspecialties, because as we get further and we're discussing these patients, they actually have, complications along the way that they may need to see other specialties. So it's really important for us to know the APPs in other areas, that when we make a referral, we make sure that we're all on the same page.
Yeah, thank you for that. Seems like a really critical connection and step. Michael, what is this connection like for you, and how are you managing that relationship? But also, do you have challenges within the context of your group practice and sort of a large network area?
Definitely. I think to address the challenges is the first important step here. This is what we had to do early on, understanding, patients fall out during treatment. Maybe the patient's not following up. Maybe we gave bad information or didn't schedule appropriately. So we've utilized, again, from an advanced prostate cancer ideology, how we would build out this advanced bladder cancer suite or treatment of therapy. And so by doing that, using that nurse navigator to make sure communication is done appropriately, I think it's taken out a lot of the missteps that we had prior. I think the follow-up, we have a very easy flow now that we have EMRs. We have easy access to patients. Even telemedicine has changed the way we've done things as well. because, being in the state of Texas, we're getting patients from sometimes 8 hours away, making sure that you're communicating appropriately with that patient before they come in. If you're having a referral from, let's say, East Texas, Tyler, making sure that patient's coming in with imaging, discs, labs, notes. And then when you talk about things within our own scope of the DFW area, we have a team of medical oncologists and also there are APPs that work in that setting. We have our own radiation oncologist in the building that we work in, and their PA that kind of floats between our space and their space. But I think also educating the primary care or the cardiology, for me, it's APPs. And I took a huge role of trying to make sure my fellow APPs were educated even 10, 14 years ago. And we do journal clubs to where we push that knowledge that we have from a urology base out to the community. And by setting up these, journal clubs, I feel like it provides good not only information but also that networking, knowing who we can call if there are side effects, specifically from a medical oncology standpoint, but also making sure primary care understands when to refer and how to refer. And there's a very easy flow. I think most APPs would agree with this in terms of the approachability between APPs, making sure those phone calls are made, making sure those notes are sent over to the PCP. If we're initiating a new therapy, maybe there's a novel therapy that the PCP did not know about. So I think when those patients are coming in, I've seen much less of a misstep in terms of that initial referral. They happen earlier now than they did even 10 years ago because that knowledge base is then being put out into the community for an understanding.
You know, that's again, what a unique role that the APP has in ensuring that all those items are connected. How do you ensure, maybe this isn't a problem, that your colleagues across specialties are receptive to this type of cross collaboration and education journal club? Do you do something unique to ensure that they want to be involved in this, or are you just finding that all of your local regional colleagues are willing to go?
No, I think it took some hand holding, if you will. Specifically when I joined this practice, coming from U.S. Oncology, where I did urology for about 14 years. When we would go out and meet these groups, these primary care, even orthopedic settings, but mainly cardiology and primary care, making sure that they could trust us with their patients when they were coming in, because I think that was a big hurdle initially was, okay, are you going to take care of my patient? And how are you going to do this? Are you going to make sure that all of your notes are being sent back? And so I think there's a trust that has to be gained. And that's why I would go in when our marketer would take us in to make sure that I introduced myself, that I gave a background, but then I also made sure the physician understood that if I was going to communicate with their APP, what that knowledge that I planned on giving them from a urology standpoint, what that might be, and that it's sound, and that we're using guidelines, bringing in the AUA guidelines, making sure they understand maybe the changes with a microscopic hematuria patient, what that guideline protocol looks like. And then that's when I would say, hey, we're going to make sure that we set up a framework of referral, that you guys can understand, that you can trust. And I think that lended itself, the availability for us to do this with their APPs, and they trusted the fact that we were making sure that we were providing good quality knowledge, but also judgment with their patients that were coming to us.
Sounds like a great best practice. I want to switch gears a little bit, Nazi, and talk about the treatment pathway and the care continuum, specifically for the bladder cancer patient, and how the APP helps to ensure a smooth process there. Thinking about your own institution and the pathway for the patient, let's talk first about non-muscle invasive bladder cancer. What does that look like after a diagnosis, and how are you helping to ensure that continuum of care and that treatment pathway?
Well, I just wanted to say that the practice of medicine has been really changed in the last decade or so, because we found out with all these new treatments and novel therapies that nobody can work in that one specialty and stay there. We have to basically, in, used to be urology just marked their territory, and that was just the urologist, and nobody else would see the patients until they have a progressive disease. But being involved with all these new treatments, multiple treatments, we learned that that can't be the case. And I think that we learned that early on, that we have to play nice with other team members, with other specialty, for the sake of the patients and for the success of our treatment plan. So we do have a network of the people in a place, but once the patients refer to us and they're coming as initial diagnosis or second opinion, obviously the diagnostic test has to be done. What's so important about the bladder cancer, and especially in non-muscle invasive area, it's really the good pathology. That would set the tone for what you tell the patients and where you go from there. You have to know, because non-muscle invasive is pretty broad term. Then you have low grade, then you have high grade, you have low risk, intermediate risk, then you have to define the high risk, because for each of that space, as small as that may look, there are novel therapies. And you obviously wanted to offer the patients the best available treatment, which is evidence-based, and you have we have a luxury of learn a lot of lessons while we're doing clinical trials. So we learn that, when we have to interfere and when we should back down, where are the areas that we lacking education for the patients and their caregivers. And I think that the APPs, that they're actually holding that front to communicate with the physician, the urologist, and also with the patients and their families, and teach the nurses, LVNs, RNs, MAs in the clinic. And it depends on what state you're actually practicing. The scope of practice actually may be different. I was talking to one of my colleagues that they practice in Arizona, and their MAs are the one that they doing the installation. In the state of California, LVN is the lowest level that they can do the installation. So your scope of practice is kind of varies. So who you have to actually educate and not, it's really kind of education by itself. And you wanted to make sure that the patient knows whoever comes in a contact with them is aware of the treatment they're getting, the side effects of that treatment, who are the people that they're in their care team, who they can call. And it becomes actually our full-time job to hold everybody's hand in the team and also in patient side.
It's a really key point, that it's like APPs in general are a very broad category, but you have to adapt the role that you play in guiding the treatment pathway and coordinating care based on your specific situation. Michael, can you talk a little bit about the treatment pathway and the role that you play at your institution, and specifically now that these new advanced therapies have come into place, even for non-muscle invasive bladder cancer? How has your role changed at all?
Sure. So I want to touch on a really important point too, and Nazi made a good point in terms of scope of practice. It does vary state to state, and I tell every single APP that I talk to nationwide, make sure you know your medical guidelines, your scope of practice for your state specific. There has been a paradigm shift too in the way APPs are involved. And I bring this up because of cystoscopy evaluations. There's still a huge split in terms of whether diagnostic or surveillance. And this brings, me to my point with the non-muscle invasive bladder cancer and how that's followed. AUA has done a very, very good job in partnering with not only, Society of Urological Nursing Association, but also the UAPA, the Urological Association of Physician Assistants, making sure that we have guidelines given to us, but also making sure that there's training, specific training for our cystoscopy evaluations, because you're starting to see a huge shift. And this happened in 2018, where they talked about the shortage that would occur in 2024, which we've seen for physicians. And the APP is really coming into that role. You're seeing more and more urological APPs than you did even 5 years ago. So I think that's a very important thing in terms of how APPs are implemented into these guidelines and how things are being followed and treated. From the muscle or the non-muscle invasive diagnosis, Nazi also brought up the point of pathology, making sure that we're getting good pathology, making sure that we're communicating with the pathologist on that follow-up, because many, many times the APP is the one that is going over the pathology with the patient. We're guiding that treatment discussion, so that initial treatment discussion, and I call it a playbook. So I give patients tons of handouts. Even if you have a QR code, I still like to have a patient take something home with them. And I try to make sure with the non-muscle invasive, if we're going to use a certain therapy, say BCG, they understand what BCG means and what's expected out of them in terms of what our protocol is for, induction versus this, surveillance type use of the medication. What BCG unresponsive, what that means. So I'm giving key points to the patient and the caregivers. And I make sure they go home with what's expected of them, but then also what is expected of us as clinicians to stick to these guidelines. Because I tell patients, if your disease state changes, we have to make sure we've done proper therapy with you up front. If you miss something, then we try our best with that nurse navigator team in terms of getting that patient back in, making sure that we have reinduction. So I give all of that information to the patient. They are aware from day one when we start our therapies, and then how they're going to be followed. Nazi also talked about the fact of these introductions, making sure the patient understands who their care team is. Making sure they understand that the nurse is going to be doing maybe a bladder installation, and I'm going to be doing all of their follow-ups, or we're going to split that follow-up between myself or the physician in a, let's say, 75% to maybe a 25% ratio, making sure that we're going to make calls to that patient. If they're having any adverse events, 3 days after an installation, what's expected of them in terms of calling us if they're having problems, because that can alter the way a treatment is given long term.
Thank you very much for that. Nazi, can you talk a little bit about transitions between providers and perhaps the role that you play specifically as an APP in ensuring that that's smooth?
Well, as I said, that it's obviously a teamwork. It has to be between the teams. It's not always in your specific department. It's obviously sometimes you have to go outside your comfort zone, and which we do with a lot of these novel treatments. So accepting that the practice has changed for APPs and also the physicians, and also knowing when your job is done and now it's somebody else's has to come in. When, for instance, we take care of this non-muscle invasive bladder cancer patients, but giving different treatments now, you see different complications. So you do have to have, so to speak, in your Rolodex, the name of other specialties that you can call on, and you can refer these patients. And also some of this therapy, you're giving it in a clinic. It's not up to the patient, so compliance is not an issue if they show up. You have a treatment plan, it's beautifully laid out, and you know your data, you know it's going to work perfectly for that specific pathology and your specific patients. They come for 2 treatments, they don't show up for 3 weeks, so you get off the charts. Then you have to make another plan, you have to make a decision, you have to do the detour. And then other thing is you have to establish a trust, which I think the APPs doing a good job with that, because we're spending a good amount of time with these patients, as Michael said, educating them, talk to them, to their caregiver, and to the patients. So we are that bridge to make sure that these patients can trust us enough to report whatever that it's the problem or they're experiencing, or the doubts that they have. I mean, we're talking about patients with cancer. Yes, we see it every day, but for that family, it's the first time. They haven't seen bladder cancer, 30 patients last week with non-muscle invasive or muscle invasive. It's for them, it's a new thing and it's scary, and they need to trust you. And these treatments that we're giving, they're obviously very effective. Otherwise, they wouldn't be in our hands to give into the patients. But anything has an effect, it has side effects. So that's where you lose the patients. They get off guard. They think, when we're talking about the novel, new, innovative treatment, they think that, oh, that means that there is no side effects. Or a lot of patients, especially in the bladder cancer area, they're older population by diagnosis. And they still think that everything you give is chemotherapy. And it's our job as an APP to basically do that education that no, it isn't, and why is it so different, but you still will experiencing some adverse reactions, and how do we plan to deal with that? Because once the patient is on treatment plan, we're owner of that patient as APPs. They're the one that the nurses will call. They're the one that their caregiver will call, the patient will call. So we have to be prepared to know the side effects and to know where to basically get that patient and refer them to the other specialty to take care of that.
Totally critical, and exactly what I was just going to ask Michael about was some of these sort of challenges to communications and timeliness, which is whether the patient has non-muscle invasive bladder cancer or muscle invasive bladder cancer, and perhaps they're receiving part of their care by another provider, and you might get information as the APP, constant contact. What tricks do you have to facilitate and ensure that the patient's needs are met in a timely fashion across specialties?
Yeah, I mean, I think too that's shared decision making. I try my best. Specifically, we'll talk about the medical oncology side of things. Before 15 years ago, there was almost a wall between medical oncology and urology, where it was, my patient, your patient. It is a shared decision. So I can't stress enough making sure that you make that point of reference in terms of who you're referring to, because that dictates everything in terms of that patient's care. Specifically, you talk about the muscle invasive side of things. We rely very heavily on our medical oncology friends. Once we refer over for them to receive whatever therapy is deemed necessary before we move into more aggressive type treatments for that disease state itself, that communication, end of week, we get phone calls. I spend probably 30 minutes, a week with a medical oncologist APP on certain patients. It's almost like, if you will, a tumor board where we're going through these patients, this Rolodex of patients for the upcoming week or what we saw this week. So making sure that transfer of care is being done appropriately, that handoff, it's almost like a baton. If you're going to run a race, you need to make sure you complete that handoff. And so we do a very, very good job from that standpoint. Now, we have hit hurdles along the way, I will say that. So we learn from those hurdles as we've hit them to make sure we don't make those mistakes. The EMR is pivotal. I think now, whether you're talking about, let's say the non-muscle invasive, making sure I told you, the protocols that we have set up for whether you're doing induction or maintenance type therapies, making sure that they hit all of their points of treatment. And EMR has done a very good job to where we can flag things that if a patient missed, let's say, installation 5 of 6, it flags us. So I can then take that, give that to my nurse navigator, say, I need you to call this patient, get them in ASAP. Whereas before, we didn't have these, let's say, flag points to where patients weren't identified, and they might go 6 months without those last 2 treatments. EMR has changed that. Also, this AI generated idea in EMR where it can pick out where things have been missed. It can generate, okay, this patient needs this therapy versus this therapy. We're still going to make the decisions. It's a shared decision again with the patient. I tell patients all the time, at the end of the day, you're going to do what you want to do. I just have to make sure I give you the proper education and treatment possibilities that you have. We'll do whatever you want to do necessary in guardrails of guidelines. So I think, being able to share and make sure that you're communicating appropriately with your referring APPs or physicians, that's done. And within our practice, it's a little bit different because we have that siloed out care, if you will. So if there's incontinence, I send over to an incontinence team. I don't do any incontinence. When it comes to the bladder cancer space, there's a very, very small subset of physicians and APPs, if you will. We are the touch points for those patients. So we own that patient's care from the time they're referred until the end of treatment. And so it makes for a very easy flow. They're seeing the same people every single time in a private practice, essentially. So it might be a little bit different than the academic setting that Nazi has talked about, because we are seeing those patients over and over and over again. So I know when a patient misses something, I put in their chart exactly what that flow of treatment should look like. And when it doesn't happen, I can identify that.
Yeah, thank you for that. I mean, that's why we have these types of discussions with 2 different clinical practice settings also, because it could relate to a lot of different types of providers. I'd like to focus a little bit on AE management for the last segment of our discussion. Nazi, I I want you to spend one moment talking to me a little bit about how you keep yourself completely apprised and educated on all these new therapies that are coming into this space, and in essence be able to communicate effectively with patients about the expected AEs, et cetera, because there's just been a plethora of new agents coming into the bladder cancer space. What do you do personally to make that successful?
That's very true. I mean, we're very spoiled because I think that in academic center, we are GU specialists. So all I do is bladder, kidney, and prostate. But even to say that, then there in each area that there are a lot of new treatments, even though that we do the clinical trials and we're running them, so we know them before that they get FDA approved. But we're not necessarily run all the clinical trials. So being involved with a lot of organizations like SUNA, ONS, and also really religiously we attend all of these AUA, SUO, and we go to the sessions. And we actually been granted this Zoom fabulous way of sitting in your living room and at 10 o'clock at night take a 2 hours as continuing education session with Enclave or other organizations. So it's really up to if you wanted to educate yourself, there is a lot of ways. And obviously, if you wanted to give the patients the best treatment available, first we have to know what is the best treatment available and what's entitled. The AEs are really important. And I think that we're losing a lot of patients uh, halfway through all these great treatments that they're available because of mismanagement of the AEs. And I think that knowing these treatments and knowing the data and the statistics and the complete response and partial response are great. But then if you cannot manage the side effects and keep these patients going on these treatments and not getting the fully time clinically that the patient needs to respond, that's where we're failing. So there is a lot of us know these drugs and we get excited about it, but then you lose the patients if you do not know the rest of the story. And most of the side effects that there are manageable if you learn how to, because, and that's where the other teams come from. I know when I have to really refer the patients to the dermatologist because that is not the rash that I can really manage anymore. Or when to refer the patients to the cardiologist because this is the hypertension I cannot manage anymore. So we have to just keep keeping ourselves educated as they come. And I think that the key point is to know the side effects and learn how to manage them.
Thank you, Nazi. Michael, any best practices that you can relay to your fellow colleagues, with regard to monitoring protocols or management protocols with some of these newer therapies?
Sure. I think from a LUGPA private practice standpoint, especially network has played a huge role. The LUGPA meetings that I go to, the bladder and kidney academies, the prostate cancer academies, those guidelines are set and we continually update. Through the years, things are updated. It's our job to make sure that we're looking at those updates because you're so right in terms of, I mean, just in the last 2 years, the treatment modalities have changed so drastically. Therapies that I never knew or even thought of, they're now at the forefront, and you have to make sure you're keeping up with the next therapy. I think, making sure, that you understand who your MSLs are for certain companies, making sure I can have those conversations. A lot of times on my lunchtime, I'll call an MSL and do a Zoom call to try to understand maybe how do I manage this side effect or adverse event versus maybe another type novel therapy that company might have. I think going to these meetings is so important because also that networking. So many, APPs. I mean, Nazi and I have been on other advisory boards where we can share this decision making and treatment options. And I learned from my other APPs across the country. I can't know everything, but I can know someone who knows something about one of the other therapies. And then I reach out to that person. So when I train APPs, I make sure that they understand you have to set that network up, whether it's in your community or whether it's in the outreaching all the way East Coast, West Coast, because, I know I can call Nazi and she's in an academic setting and say, hey, what are you guys doing a little bit different with this treatment modality? Because I'm having some problems with outcomes. Have you seen this? So, I can't pick up a journal article sometimes and get the direct feedback that I would if I called Nazi on a Wednesday afternoon and say, I'm not seeing what the, treatment I thought would work for this patient. Have you had this happen? So it's that communication. It's also communicating with the patient too, and making sure they understand, like Nazi said, a lot of these AEs are manageable. You just have to know when to manage up front. And the patient has to know too, again, setting an understanding up front with the patient, this may or may not happen based on what we learn from certain, papers, certain knowledge-based guidelines. And then also knowing when to refer. I refer a lot of times to our hematology oncology friends. If you have a more advanced disease, making sure you know when to refer over, or does that patient need to be seen in the ER and the ICU? So I make sure that if I have a patient that I'm seeing in clinic that is having an AE that is not going to be able to be managed in clinic, I get them over across it's literally across the hall in our practice, over to the emergency department. I call that oncology APP and say, hey, you are the physician to come to the hospital after work. And can you give me some insight on what we need to do next for this patient? Again, that's that trust. Because I'm not going to use the phone a friend to every single patient, but when I need that help, I know who I can reach out to, and they'll help manage that patient as a team.
Yeah, thank you for that. Nazi, any proactive measures that you as an APP can initiate to prevent escalation of some of these AEs? Because I know some of these things start small, but can get pretty out of hand pretty quickly.
True. And I think that what I wanted to add to what Michael elegantly said, when you look at our practices, if it's the urology practice like Michael in, or academic center like I am, we do have urologic oncology. If you work with bladder cancer, prostate cancer, or kidney cancer, you're in urology, but you're doing oncology. Either you like it or not, you can't. As Michael said, if he has incontinence, he will refer the patient because he doesn't do general urology. So as like the other urologists who go through 3 years of fellowship and become urologic oncologists, I think that maybe it's not as structured, but if you're an APP and you're in urologic oncology and you're in urology practice that you see cancers, then we, like it or not, become half oncologists, half urologists. So you do have to have that education to back it up. And that comes with all the tricks that we know to prevent some of the side effects from happening. And some of it is very simple, and people don't really take that to time to sit with the patient and basically just say, when I'm giving you BCG for the first 2 hours, I want you to go and void, but after that, I want you to flush your system. I want you to hydrate. That helps actually with a lot of side effects that they have with dysuria, problems when the BCG, they void. It's the same thing with immunotherapy. You do not have a big Steven Johnson syndromes or any other big dramatic dermatology problems. They start with a little rash. So all you need to basically tell your patients that I may not actually do the full body physical when you're coming to see me, but I want you to do the full body physical on yourself before you come to see me. It could be in the back of your neck and I can't see, or it can't be in the back that I can't see. So, because some of these rashes, for instance, they're not really symptomatic. You may have a rash, but it's not comes with the itching. And then by the time that it takes over 25% of their body surface area, then you're in trouble. So preventing everything is to basically teach the patients to look for the signs that we can tell them. If you have a headache, I don't want you to just say, well, I have a cancer, I'm probably not. Just, you have to report that to us. Let us make that decision that if this is just a normal headache or we actually wanted to do something about it. And, as nurses and being in the space of APPs, we do a lot of really simple educations that I just basically go around and tell everybody, like, have you wear your sunscreen today? I just like, you just tell the patients, it does help because, you don't want anybody to be dehydrated or be under the sun while they're receiving immunotherapy because their skin is already inflamed and you don't want it to add to that inflammation. Some of this education can be as simple as that. And
Yeah.
some, yes, you need to have subspecialty to hold your hand through it.
Yeah. Thank you for that. Any other comments from your side on preventative measures from an APP perspective? It sounds like, awareness and taking the time to educate the patient is a real, true APP priority. But anything else, Michael?
Yeah, like I said, I think if you're upfront with the patient and their care team at home, I think it's important. Many times when I do these discussions, I ask, are you living with someone, or do you have a son or daughter that's going to be taking care of you? Do you have a home health care nurse that we need to discuss potential AEs with? And I try to get those people, if they can't come in, because it's a huge burden on the extenders of a family to come into every single appointment. So I try to get those people on Zoom or I'll call them FaceTime and have them understand, okay, these are what our expectations are. These are what potential problems could look like. But also, again, like, I'll go back to the nursing team. My installation nurse, she has handouts for every single treatment modality that we do. And when that patient comes in for that initial treatment, she gives them a handout and tells them either you put this on your mirror in your bathroom or you put this on your refrigerator when you go home. And these are the rules that we're going to follow as we go through this. So the patient has that protocol understanding of what's expected of them when they leave the clinic. We use that nurse navigator to call after we initiate. She's calling them at 2 or 3 days after, making sure that it's not just a low-grade fever. These flu-like symptoms. Is the patient actually becoming septic? Do they need to be seen? And I tell every single patient when I see them initially, if it's a problem for you, it's a problem for me. I don't want you to just blow this off. You need to call and get in. We have, a care pathway specifically for you. Use that care pathway. Make sure that that dysuria doesn't turn into a full-blown urinary tract infection. We could just culture, treat, and see you back accordingly.
Yeah, thank you for that. Great summary. Just a few closing questions for you. Maybe I can ask Nazi, how do you envision the role of the APP evolving within the team over the course of the next 6, 18, 24 months, particularly given how the treatment paradigm is really changing quickly in bladder cancer?
Well, I have to tell you that in last 26 years that I actually been an MP, and I've been in this practice, that I seen the role of the APPs evolve drastically for obviously better. And I think the value of the APPs are just basically unfolding as these new treatments are coming along. And we're doing a lot of basically chemical and systematic ablation rather than going to take the patients to the surgery and cut it out. So we have actually more value for APPs to basically be part of this plan and navigate through these treatments and take a reign basically of doing this. Like we did 12, 15 years ago when they had the first immunotherapy for prostate cancer. Nobody in urology clinics wanted to give infusion, and it was 30 minutes infusion. And it was the surgeons who going and do a nephrectomy and cystectomy and all these complicated surgeries. They didn't want to give 30 minutes infusion in urology clinic. They didn't want to touch anything IV in urology. Everything has to be like installation. Well, that has changed because the APPs, the one that they said, well, I can give the infusion, it would be okay. So I think that for this new treatment, as we're seeing that it's kind of combo of installation, sub-Q or IV treatments, and comes as a package, then you either have to have a great group of people that you work with in medical oncology, and you have to really work with them, because I think the shift would be the urology would feel more comfortable giving the IV or sub-Q treatment before the medical oncology feel comfortable doing installation.
Thanks for that perspective, Nazi. Michael, you've given us a lot of best practices on communication and collaboration across the MDT. Are there tools or practice changes or even resources that you can recommend to other APPs to get up to speed and maybe hone in on some of those?
Yeah, I think the AUA has great tools. They've done a very good job. I mean, you can download an app on your phone now and take that in. I think that making sure you stay up to date on those guidelines, that really changes the way we practice. It also holds us to accountability. I tell everyone, you have to take your job very seriously because this is a very, very complicated space. So staying up to date on what those guidelines may or may not be, because the guidelines that we used 10 to 15 years ago, Nazi can, she can say this, 26 years worth of experience. Things have changed and they're ever evolving. And it's also taking that ownership of what you're actually doing in clinic. And I think that's where APPs, this has changed because now you're starting to see more tenured APPs that have been in the field for 10 and 15 and 20 years. We are sometimes the front line for a lot of these patients. We are the ones that are doing more of the, in-office setting procedures where I say a lot of the physicians, they did surgical training. I try to keep them in the OR to do these bigger, complicated cases. I also have conversations with patients too. We didn't have a lot of these therapies in terms of organ sparing type therapy before sending into a radical cystectomy. Because before, a lot of patients would think, okay, well, this is just a death sentence. No, I mean, we can expand and extend your life significantly more than what we could, 10 years ago. We have these options that we can give you. It's also that education, like I said, staying up to date on what those new treatments are, communicating with maybe an MSL or a rep, understanding what is coming down a pipeline in terms of conversations with patients. So I think, as an APP, we do have to take that ownership, and it's a heavy burden sometimes, but I think that this is going to be the forefront of urology, specifically oncologic urology, in terms of what that APP's role, because of the burden that has been taken on the physician role and the shortage that's coming down that pipeline as it continues.
Thank you very much. Thank you. I really appreciate both of you and your insights that we've captured this evening. And I don't think I have any further questions.
Thank you for having us.
Thank you.